All right, welcome. Today we are diving deep and decoding cerebrospinal fluid, focusing on its clinical chemistry, diagnostic analysis, and maybe most importantly, the art of interpretation. And the big idea really is this. CSF is not just brain blood. Not at all. It's a selective ultrafiltrate, it's a protected environment, and it acts like a chemical record of the central nervous system's health. So what does that mean for us? It means to diagnose anything we have to think like detectives. Our job is to separate the signal, the real clues about a disease from all the background noise of passive filtration. So, let's dive in. So, here's how we're going to break it down. First up, we'll look at CSF formation and the blood-brain barrier. We have to start at the source. Then, we're going to do a real deep dive into protein analysis. This is the core evidence in our detective work. After that, we'll check out some key metabolic markers, which are like the supporting clues. And finally, we'll pull it all together with clinical interpretation and a solid set of rules to guide us. Okay, let's kick things off with our first section, CSF formation and barrier. You know, it's so important to get a handle on this first because where this fluid comes from and how it's made, well, that dictates everything about how we're going to interpret what we find in it.
Okay, so this diagram really lays it all out for us. On the far left, you've got plasma. And just look at how complex it is. It's jam-packed with cells, antibodies, big proteins, a really busy place. Then it hits this filter in the middle, the choroid plexus, which basically forms the blood-brain barrier. Now, this is not a simple kitchen sieve. It's a super selective, tightly controlled barrier. And what comes out on the other side? The cerebrospinal fluid. See how much cleaner it is? Just a few cells, some small molecules. So let's break this down. First, formation. CSF is made by plasma getting filtered through this choroid plexus. And this brings us to a golden rule, and you gotta remember this. CSF reference values are not the same as plasma values. They're two completely different worlds. The mechanism behind this is that the blood-brain barrier is super strict about what it lets through, keeping out big molecules like proteins. So the implication here is massive. Something weird in the CSF doesn't always mean something's weird in the plasma. It reflects what's happening specifically inside the central nervous system.
So now that we know where CSF comes from, let's move on to our next section, the protein analysis deep dive. And if we're playing detective, this is where we find the real smoking gun. This is going to be the most detailed part of our whole investigation, and for a very good reason.
So just look at this visual for a second. It says it all. On one side of the scales, you have this huge weight for serum protein, which we measure in grams per deciliter. And on the other side, this tiny little weight for CSF protein, measured in milligrams per deciliter. That massive difference is our first big clue. For starters, the typical reference range for total protein in CSF is only about 15 to 45 milligrams per deciliter. And this is the critical distinction. CSF is measured in milligrams, not grams. Its concentration is roughly 1/200th of what you'd find in serum. The physiology behind this is pretty straightforward. Normal levels are super low because that blood-brain barrier we talked about keeps those big protein molecules out. We do see some natural variations, though. Levels are a bit higher in infants and in adults over 40. And as for methodology, in the lab, this is measured using turbidity or dye-binding methods.
So if the total protein is different, what about the actual types of protein? This slide's perfect for that comparison. All right, look at the serum protein chart on the left. It's mostly albumin and globulins, right? Now look over at the CSF protein chart. Albumin is still the biggest piece of the pie, but look what's second. Prealbumin. That's a huge difference from serum. And then you have this totally unique thing, tau transferrin. It's a special form of transferrin that you only find in CSF. That's why we call it the CSF ID card. If you find it, you know for a fact you're looking at cerebrospinal fluid. The gamma globulin part is mostly IgG, and here's something really important. There are proteins that should be absent in health. Big molecules like IgM, fibrinogen, and beta-lipoprotein. You just shouldn't see these in healthy CSF, period. Okay, so what's going on when the total protein is high? Well, there are four main reasons. First up, we have BBB damage. You can see it here, like a broken wall with stuff just leaking through. This increased permeability lets blood proteins pour into the CSF. You'd see this in something like meningitis or with a tumor. Second, intrathecal production. The picture shows a little factory inside the brain making antibodies. This is when the central nervous system itself is cranking out immunoglobulins, a key finding in multiple sclerosis or neurosyphilis. Third is decreased clearance, which you can see visualized as a clogged drain. The fluid just isn't getting cleared out properly, so proteins build up. And finally, number 4 is neural tissue damage. The image shows a neuron breaking down, releasing its proteins right into the fluid.
Okay, so how can we tell if protein is just leaking in from the blood or if the brain is actually making it? Well, we've got these clever indices. Let's look at the wall check first. This checks how intact the blood-brain barrier is. The formula is just CSF albumin divided by serum albumin. And the logic is really simple. The brain doesn't make albumin, so if it's in the CSF, it had to have leaked in from the blood. The rule of thumb, a value less than 9 means your blood-brain barrier is intact. Now for the factory check, or the IgGIndex. This formula is a bit more complex. It's a ratio of ratios, but its job is to check for local IgG production while correcting for any leakage from the blood. The rule here, if the value is greater than 0.70, that's a good sign that the CNS is in fact synthesizing its own IgG. This gel right here shows us a classic example of one of the most specific findings you can get, oligoclonal bands, or OCBs. Look at the lane for serum. The gamma region is just kind of a diffuse smear. But now look at the CSF lane. See those sharp, distinct bands? That is the MS pattern. By definition, OCBs mean there's localized IgG production, and this leads to a golden rule. You have to run a serum sample at the same time. The interpretation is pretty black and white. If you see bands in the CSF only, that points to inflammation in the central nervous system, like in multiple sclerosis. But if you see the bands in both the serum and the CSF, that suggests a body-wide systemic issue. For MS, finding 2 or more of these unique bands in the CSF is the real hallmark of the disease. While OCBs tell us about synthesis and production, another protein, myelin basic protein, or MBP, helps us track active destruction. The picture here shows a nerve's myelin sheath, literally breaking apart. MBP is a key part of that sheath, so its significance is huge. Finding it in the CSF means there's active demyelination. The destruction is happening right now. And here's the key clinical application. OCBs can hang around for years, but MBP really tracks what the disease is doing at this very moment. It's used to monitor the current state of a disease and see how a patient is responding to treatment.
All right, that was a deep dive on proteins for sure. So now we're moving on to our third section, key metabolic markers. You can think of these as the supporting clues that really help flesh out the story. We're talking about glucose, lactate, and glutamine. First up is glucose, and I love how this slide shows it as the consumption test. These fuel gauges tell the story perfectly. So plasma glucose is our 100% full tank. Normal CSF has about 60 to 70% of that. But look at bacterial meningitis. The gauge is almost on empty. And why? The core concept is that bacteria gobble up glucose for energy. Viruses don't. And that's why there's this critical 2-hour rule. You have to draw blood glucose about 2 hours before the lumbar puncture. That gives things time to equilibrate. Without that baseline blood value, the CSF number is really hard to interpret. So the pattern is pretty clear. Decreased glucose suggests bacterial meningitis, while normal glucose points towards a viral cause. Next, we have lactate, which we're calling the independent variable. It's often more sensitive than glucose, and a huge advantage is that it's independent of what the plasma levels are doing. This spectrum visualizes it beautifully. Levels under 25 milligrams per deciliter, that's consistent with a normal or viral state. As we move up the scale, levels over 25 suggest a bacterial, tubercular, or fungal infection. And way over on the right, a level over 35 is a strong bacterial indication. Its key advantage is that it's a really reliable early marker. But we do have to be careful about potential false positives that can be caused by things like a head injury or even just sample contamination. And our third metabolic marker is glutamine, the ammonia trop. This diagram shows how the CNS has this clever way to protect itself. Ammonia is really toxic to the brain, so the brain takes it and combines it with alpha-ketoglutarate to make a non-toxic molecule, glutamine. But what happens if there's just too much ammonia? As that red arrow shows, you get a buildup of excess glutamine, and levels over 35 milligrams per deciliter are linked with a disturbance of consciousness. The mechanism is that the brain is producing this glutamine to detoxify ammonia. We see this happen in things like liver failure or Rey syndrome, and this can all lead to what's known as the crash. When the ammonia just overwhelms the system, you can have a full-on metabolic crash in the brain. Okay, so we've gathered all our clues, the proteins, the metabolites. Now for our final section, let's put on our detective hats and focus on clinical interpretation, putting all these pieces together to actually build the case. This meningitis differential matrix is the perfect example of how you build a case. Let's compare these conditions. First, let's look at the bacterial profile. Glucose is way down, markedly decreased. Lactate is high, usually over 35. And the cells you see are mostly neutrophils. Now let's compare that to tubercular meningitis. Glucose is decreased, but maybe not as low. Lactate is elevated, over 25. And here, the main cells are lymphocytes. And finally, look at the viral profile. Glucose is normal.
Lactate is also normal. And the cells, again, are mostly lymphocytes. Seeing these patterns right next to each other makes the diagnostic power of these tests incredibly obvious.
This diagram is a really powerful way to think about the why behind all these weird results. Right at the center of it all, you have pathology, some kind of disease process. And this central problem can cause one or more of 5 things to happen downstream. It can cause barrier dysfunction, which we measure with that albumin index. It can trigger intrathecal synthesis of antibodies, which we find with the IgGIndex and OCBs. It can cause tissue destruction, releasing MBP. It can lead to hypoxia, causing high lactate. And it can result in metabolic failure, which we'd see as high glutamine. It all comes back to this quote at the bottom. Understanding the mechanism is more important than memorizing the numbers.
And that brings us to maybe the most important point of all, clinical integration. This puzzle visual really says everything. The final diagnosis is made up of multiple pieces. Our focus here, chemistry, it's a huge piece of the puzzle, for sure, but it's not the whole puzzle. It has to connect with the microbiology findings, the physical exam, and of course, the patient history. The text here is clear. CSF chemistry has to be correlated with clinical symptoms and other lab values. The core principle to always remember is that isolated chemical results almost never give you the diagnosis all by themselves.
So to wrap this whole thing up, let's go over the 6 golden rules of CSF analysis. These are the things you absolutely have to remember. Number 1, different worlds. CSF reference values are fundamentally different from plasma values. Number 2, the units. Always check your units. CSF is in milligrams per deciliter. Serum is in grams per deciliter. Number 3, the ratio. You always have to evaluate albumin and IgG relative to the serum levels by using the indices. Number 4, the timing. Remember to draw blood glucose about 2 hours before the lumbar puncture. Number 5, the method. For electrophoresis, you need simultaneous serum and CSF samples to do a proper comparison. And finally, number 6, the diagnosis. OCBs in the CSF only? That suggests a mess. OCBs in both serum and CSF? That suggests a systemic condition. Following these rules helps make sure we're not just reading numbers off a page. It ensures we are truly decoding the chemical record of the central nervous system. Thanks for joining this explainer.